So, Dr. Carlos Cortés Villar, it's a pleasure meeting you in this interview. We will go through a couple of the QFR items. You have a lot of experience in that. But before we start with the questions, can you introduce yourself, who you are, where you work, what you're doing?
Okay, of course. I'm Carlos Cortés. I'm interventional cardiologist at Miguel Servat University Hospital from Zaragoza in Spain. It's a pleasure to be able to have this conversation. I started using QFR in 2016 when I was in Valladolid. We began to use it in the cath lab, being one of the first centers in Spain where it was used.
Yeah, okay, so you have really an enormous experience already.
Yeah, I guess so.
Yeah, no, absolutely, 5 years, so that is enormous. And that is also what we see from exchanges of data that you have done and some tests for us. That's always a high quality. So in your current hospital, can you say something about how many cath labs do you have? How many PCIs per year? How many FFRs do you do? And how many Qfrs? Can you explain that a little bit of the infrastructure?
Yeah, my cath lab, we have 2 cath labs in my hospital. We perform around 1,200 PCI per year. The use of coronary physiology tools is increasing every year. FFR and IFR, we have reached around 200 cases in the last year. This trend is being seen in most centers since this is solid evidence telling us that decision-making based on isolated angiography is not enough. QFR is increasing. QFR appears in my cath lab when I reached Zaragoza 1 year ago. From this moment, we introduce for my colleagues the new technology, and its use has been increased every day, every month. And now we perform a lot of QFR in clinical application.
So that was also one of my questions. I mean, you have an extensive experience with the QFR. You've used it in clinical research, but now also in daily clinical practice. I mean, do you do both clinical research and the daily clinical practice? Is that a combination?
Yeah, of course. In clinical research, we have investigated its use in non-critical lesions. We also have tested against FFR and RFR in stable coronary disease. This research has been published. We are now conducting a multi-center study evaluating its 5-year prognostic value. We are going to present the preliminary results at the Congress of the Spanish Cardiology Society and the next TCT.
Also at the coming TCT. Okay.
Yeah. Like a poster.
Yeah. Okay. Then we need to follow that up and use that material also, of course, in our QFR newsletters and other, say, social media announcements that we are doing. It's always very important that we follow up on everything that our, say, users, the QFR users, do and present at the different meetings. So in your daily practice, where do you see its usage most? Is it selection of the vessels? Is it prioritization of the narrowings if you have multiple stenosis? Is it post-PCI? If it is, I mean, I believe also you do if you have the non-culprit lesions, you treat the patient and patient stays in the hospital maybe or comes back, and you need also to decide whether you need to treat the other vessels. So where do you see most applications?
Yeah, I think the main advantage I see is a very complete technology. Not only tell us which lesion to treat, but also tell us how to treat them. I mean, it indicates the length and the diameter of the stent we must use. Moreover, that the lesion, as you say, it will give us a Qfrs value of each stenosis separately, allowing us to choose how to treat them better. About non-crucial lesion is the first clinical use we start using. After doing a primary PCI, almost half of the patient will find stenosis in other arteries. Worrying about these lesions with unstable patient, often in the middle of the night, is not practical.
Yeah.
With Qfrs, we can analyze next morning if the lesion is significant and only bring it back to the cath lab if the Qfrs is positive.
Yeah.
As I mentioned before, we have checked this strategy, and other groups have worked in the same direction.
Yeah. So then, if you treat the patients in the middle of the night, you also make additional acquisitions so that you have all the vessels in acquired images of all the vessels, so that you can do the next day the Qfrs analysis.
Yeah. With this strategy, we avoid unnecessary procedure for the patient. Yeah. The length of the stay, the hospitalization stay decrease with this strategy, and the risk for the patient decrease also. Yeah,
no, absolutely. And what I also often hear is that also the time that you need for a procedure is decreased by using the Qfrs instead of say unwrapping a wire, placing the wire into the vessel. It all takes time. Of course, you need to add adenosine and so on. And with the Qfrs, if you have a little bit of experience, or if you have an experienced technician, you can very readily do a Qfrs. That is also how you see that it improves the workflow in the cath lab.
Yeah, as I mentioned, avoiding unnecessary staged intervention for me is the best application I find. Second, expanding the functional evaluation of coronary stenosis. We should not treat stenosis based on isolated angiography. With this, we avoid unnecessary use of stent, minimizing risk and complication. Qfrs, as you say, makes coronary functional assessment cheaper and easier, and that's why, from my point of view, this should let us to stop making decisions based only in visual estimation. It's not good enough.
Yeah. And as you mentioned also earlier, do you use the 3D QCA data also for stent sizing? Do you look at the reference diameters, the length of the narrowing, and so on for choosing the proper size of the stent?
Yeah, definitely. Yeah, because as I mentioned, not only I see if I have to treat the lesion. Also, Qfrs give me information about the length, that in more times is very important because we use less contrast, because we have to use less acquisitions analyzing by Qfrs.
Yeah. No, that's a very good point, and that is also what we often emphasize, that we are always talking about the Qfrs as a measure to determine the physiologic significance of the narrowings, but it's often forgotten that at the same time the 3D QCA data is available, and that can be used for vessel sizing or stent sizing. So it's not always, I do not always hear it, I would say, but I mean, what you do is great. You use both anatomic information as well as the physiologic information. So you combine, say, both worlds in a very practical manner. Is there something that, with all your experience in the Qfrs, that you say, well, this is something that I would like to see next in the Qfrs? What are your wishes?
My wish for the future probably is ask a lot, but my wish for the future would be a tool, the one we can calculate the microvascular resistance based on this technology. I think it would be great.
Yeah. Well, and as you probably know, and there have been publications in the field, we also have a research solution now available. So I think it would be really great if you could also start working with that and get an experience it's very simple actually. It's a simple addition. We only need to add the aortic pressure, the mean aortic pressure, and then you can measure the angio-based IMR. So we are testing that now in a limited number of cases, but given all your experience in this field and your 5 years experience, I think it would be very logical also to add the number of sites that are working with the IMR as well, and also get your experience.
Yeah.
And for that, of course, you need also the flow velocity, and that is also a solution that we will bring out now in the coming release, where we do automated frame count, and so that in the 2 views you will also measure and get the numbers presented about the coronary flow velocity, and that is as you need that also for the IMR calculations.
Yeah,
so,
yeah.
I'm sure you will enjoy the next version.
I'm sure. I'm sure also.
Yeah, of this release that will come shortly, and then of course, yeah, we are always looking forward to further such suggestions and comments from the expert users. So what we would need to do next, and also learn from you, because you are the ones who are using it in daily clinical practice, and so that is very, very valuable information. So I think we will be in contact very soon again with the next steps, and like I said, we like to learn from you and also see your publications. I know that you have also been testing these flow velocity measurements and got great results. And that is also, of course, also our goal, to make it as simple and as flexible and automated as possible. And these are major steps that we are taking. So I think with these points, I would like to thank you very much for this interview, and then we will be in touch for the next steps. So
thank you for the opportunity for test the new technology. I'm very privileged, and when you need.
Thank you so much.
Thank you so much.